Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. Willkommen auf den Kanal für Anästhesie und Perioperative Medizin. Bienvenue sur la chaîne Anesthésie et Médecine Perioperatoire. Benvenuti al canale dedicato ad anestesia e medicina perioperatoria. Welcome. Today, we're going to be doing a really deep dive into the perioperative management for what is, let's be honest, one of the most demanding procedures in all of modern surgery, the pancreatic resection.
And this slide really sets the stage, doesn't it? It's a stark reminder of the challenge we're facing. For every 1,000 patients diagnosed with pancreatic cancer, the path to long-term survival is, well, it's incredibly narrow, only about 150 or even potentially resectable at the time of diagnosis. And after a truly grueling journey of optimization and major surgery, a mere 24 might see that 5-year mark. This isn't just a surgical problem, it's a monumental perioperative challenge, and that's where we come in.
So, to really get to grips with how we can improve these outcomes, we're going to follow the patient's journey. First, we'll unpack the surgical challenge itself. What are our colleagues actually doing? Then we'll look at getting the patient ready for this marathon. We'll dive into our specific role intraoperatively, explore the impact of new frontiers like robotics and ERAS, and finally, we'll talk about navigating those all-too-common post-operative complications. Right? Let's jump in.
Right then, first things first. Before we can even begin to think about our anesthetic plan, we have to have a profound respect for the anatomy and for the procedure itself. A pancreaticoduodenectomy is, without any question, one of the most anatomically complex operations routinely performed today. So here's the formal definition. It's an en-bloc resection, which means all these structures are removed as a single, contiguous unit to get the best possible oncological clearance. This procedure was first pioneered way back in the 1930s by Dr. Alan Whipple. And while the techniques have been massively refined since then, the fundamental physiological insult remains immense. Mortality has thankfully dropped from over 25% in the 1960s to well under 4% in high-volume centers. But morbidity, the complication rate, remains stubbornly high. Now, what's really interesting here is how the technique has evolved. We have the classic Whipple, and then we have the pylorus-preserving pancreaticoduodenectomy, or PPPD. The key difference, as the name gives away, is the preservation of the pylorus and the distal stomach in the PPPD. Now, the goal was noble, to improve long-term gut function and reduce that nasty dumping syndrome. But it comes with a trade-off. It has a well-documented higher incidence of delayed gastric emptying, or DGE, which can be a massive headache and significantly prolong the patient's hospital stay. Interestingly, a Cochrane review found no major differences in mortality or survival, so the choice often just comes down to surgeon preference and the specific location of the tumor.
And this picture illustrates the sheer scale of the operation just brilliantly. On the left, in panel A, you can see that shaded area representing the huge resection, the head of the pancreas, duodenum, gallbladder, bile duct, and part of the stomach. But then look to the right, at panel B. That's the intricate plumbing job required to put everything back together. It is absolutely our job to understand the physiological implications of each of these new connections.
This reconstruction is really a triad of anastomoses, and they're usually performed in this exact order. First, the pancreatic remnant is joined to the jejunum. That's the pancreaticojejunostomy, or PJ. This is widely considered the most technically demanding part, and it's truly the Achilles heel of the operation, carrying the highest risk of a leak. Next is the hepaticojejunostomy, or HJ, to restore the flow of bile. And finally, the gastrojejunostomy, or duodenojejunostomy, depending on which resection was done, to get food passing through again. Each of these is a potential point of failure that we need to be mindful of.
With that surgical challenge now clearly in view, let's turn our focus to the patient. These individuals are almost never ASA1. They're often elderly, they're malnourished, jaundiced, and deconditioned from their cancer and its treatment. Preparing them for this surgical marathon is, and I can't stress this enough, absolutely critical.
So the very first step is figuring out if surgery is even a realistic option. The National Comprehensive Cancer Network, or NCCN, gives us very clear criteria based on high-quality CT imaging. And it all hinges on the tumor's relationship with the major vessels sitting just behind the pancreas, specifically the superior mesenteric artery and the superior mesenteric vein. If the artery is encased by a tumor, that's an absolute no-go for surgery. But if there's just venous involvement or the artery is only abutted, it might classify the tumor as borderline resectable.
The whole surgery-first paradigm is now being seriously questioned. Now, while the NORPACT-1 trial didn't show a benefit for neoadjuvant therapy in strictly resectable cases, the Preopanc trial did show a survival advantage in a mixed group of patients. So what's the bottom line here? Well, neoadjuvant therapy serves two really important purposes. One, it can actually downstage borderline tumors to make resection possible. And two, perhaps even more importantly, it acts as a biological stress test. It weeds out patients with really aggressive disease who progress despite the chemo, and it spares them a futile, massive operation.
This statistic is just incredibly sobering, isn't it? It hammers home the point that our goal isn't just to get the patient through the operation. It's to get them through it well enough to receive the adjuvant chemotherapy that we know improves their long-term survival. A technically perfect but physiologically devastating operation is, in the end, an oncologic failure. And this really underscores the massive importance of preoperative optimization.
So what can we actually do about it? Well, there are three key areas. First, we risk stratify. CPUET is an absolutely invaluable tool. Variables like the anaerobic threshold correlate directly with the risk of major complications, including that dreaded pancreatic fistula. Second, we have to address nutrition. Malnutrition is rampant in these patients, and it must be treated aggressively, preferably with enteral feeds, as TPN can actually increase infectious risks. And third, biliary drainage. Now, it seems intuitive to decompress a jaundiced patient, but routine stenting when the bilirubin is below 250 micromoles per liter is actually associated with more, not fewer, septic complications, so it should be avoided.
Okay, time to dive into our specific role in the operating theater. Our management here directly and profoundly impacts patient outcomes. And here we are. We've arrived at arguably the most debated topic for anesthesiologists in pancreatic surgery: fluid management. It is such a delicate balancing act. On one hand, we absolutely have to maintain organ perfusion during a long, major operation with significant third space losses and the potential for a lot of blood loss. But on the other hand, we know that excessive fluid leads to tissue edema, which can seriously jeopardize those fragile new anastomoses.
What's absolutely fascinating here is the paradigm shift that we're all witnessing. Traditional ERAS protocols preached a very, very restrictive, near-zero fluid balance. The fear was creating what some called the drowning Whipple, a patient with so much tissue edema that their gut fails and their anastomoses leak. However, more recent large trials, like the RELIEF study by Miles and colleagues, have shown that this ultra-restrictive approach might come at a cost, namely a higher incidence of acute kidney injury and surgical site infections.
And this really is the crucial point. We are moving away from a one-size-fits-all recipe of, say, 1 to 3 mL per kilo per hour and moving towards a truly individualized approach. The consensus now is strongly in favor of goal-directed fluid therapy. This means we should be using dynamic parameters of preload responsiveness, things like stroke volume variation or pulse pressure variation from our arterial line, or even non-invasive cardiac output monitors, to guide our fluid boluses, giving them only to the patients who will actually respond to and benefit from them.
Analgesia presents a very similar balancing act. For open procedures, the thoracic epidural has long been our gold standard, and for good reason. It provides excellent pain relief. The problem is, the significant sympathetictomy it produces can cause hypotension, which then complicates our goal-directed fluid therapy. It can lead to what you might call epidural-driven fluid resuscitation and vasopressor use, which really muddies the waters of our hemodynamic assessment. For minimally invasive cases, or if an epidural is contraindicated, a really robust multimodal approach using regional blocks like rectus sheath catheters, combined with systemic agents like IV lidocaine and ketamine, can provide excellent opioid-sparing analgesia with much greater hemodynamic stability.
And when hypotension does occur, despite our best efforts, which vasopressors should we be reaching for? Well, there's a real theoretical concern that pure alpha agonists like phenylephrine could disproportionately constrict the splanchnic circulation. And why does that matter so much? Because that is the very blood supply we need to protect for gut and anastomotic perfusion. Therefore, norepinephrine is generally the favored agent. Its beta agonist effects help to maintain cardiac output, and it provides a more balanced physiologic response. The evidence base here is still evolving, but this is definitely the current best practice.
Now that we've covered the core intraoperative challenges, let's look to the horizon. Let's talk about the innovations that are really reshaping this field: robotic surgery and enhanced recovery protocols.
Minimally invasive pancreatic surgery has been a long time coming, and that's because of the sheer complexity of the procedure. The arrival of the surgical robot has been a potential game changer. However, the learning curve is notoriously steep. Studies show that a single surgeon needs to perform somewhere between 20 and 40 robotic pancreatectomies just to get past that initial, most difficult phase.
But overcoming that initial curve is not the same as achieving true mastery. More recent data from high-volume centers suggests that true proficiency, where your outcomes become consistently superior to the open approach, may not actually be reached until after an incredible 250 cases. It's a number that really drives home the point that this type of surgery should absolutely be confined to dedicated, high-volume centers.
But once that proficiency is achieved, the benefits do become quite clear. This chart nicely summarizes the findings from several large studies. Robotic pancreatectomy, or RPD, is consistently associated with significantly less intraoperative blood loss compared to the open approach. And perhaps more importantly, from an oncologic perspective, RPD is associated with a higher lymph node yield. Now that is a crucial marker of surgical quality, and it has real prognostic implications for the patient.
However, we simply can't ignore the massive practical barrier to wider adoption, and that is the cost. The true Achilles heel of robotic surgery is the very high initial capital outlay for the robot itself, plus the not insignificant per-case cost of the disposable instruments. It creates a financial barrier that really limits its widespread adoption, despite all the potential clinical benefits.
So let's turn to a more accessible innovation, enhanced recovery after surgery, or ERAS protocols. This isn't about one single piece of fancy tech, but a whole bundle of evidence-based perioperative care elements all working together. And as this chart shows, the impact is profound. A recent meta-analysis showed that implementing ERAS reduces overall complications by 18%. But it also specifically targets our most troublesome issues, reducing delayed gastric emptying by 31% and that dreaded pancreatic fistula by 24%. It shortens hospital stay, and critically, it does all of this without increasing the rate of readmission.
And finally, despite meticulous surgery, perfect anesthesia, and protocolized care, complications are still going to happen. Our role as perioperative physicians extends well into the post-operative period, where early recognition and management are absolutely key to a good outcome.
This table is really your high-yield summary for clinical practice and for your board exams, too. These are the top 5 complications that we all worry about. The most common are pancreatic fistula and delayed gastric emptying. Post-pancreatectomy hemorrhage is less common, but it can be lethal, especially the late bleeds. Those are often due to a pseudoaneurysm eroding into the gut and frequently happen in the setting of an underlying pancreatic leak.
Let's just focus for a moment on the most feared complication, the pancreatic fistula. It's so important that we all use the standardized definition from the International Study Group for Pancreatic Surgery. A leak is only officially a fistula if the drain fluid amylase is more than 3 times the serum upper limit of normal on or after postoperative day 3, and it only becomes a clinically relevant fistula or a CRPOF if it actually leads to a change in clinical management, things like prolonged drainage, antibiotics, a trip to interventional radiology, or even a return to the operating theater. This is the complication that drives sepsis, hemorrhage, and ultimately mortality.
So when we bring all of these different pieces together, the incredible surgical complexity, the fragility of the patient, the intraoperative balancing acts, it really begs the question on this slide. What is the future of pancreatic surgery? And more importantly, what is our role within it? With high-tech robotics facing these cost barriers and complications remaining a stubborn reality, where do the truly meaningful improvements lie?
And I think the answer, fundamentally, is us. The future isn't just about a better operation, it's about a better patient journey. Our role is evolving from simply being the provider of anesthesia to becoming the perioperative physician who really architects that journey, optimizing the patient from the moment they step into the clinic, guiding them through the crucible of the operating room, and into a recovery that's strong enough for the fight that's still ahead. The future gains will depend less on surgical technique alone and much, much more on our continued mastery of these comprehensive perioperative strategies.